Hello, today I'm going to be talking about some of the key studies in the field of breast cancer presented at the ASCO 2018 meeting in Chicago. The key studies that I want to focus on fall into three areas. The first is about de-escalating therapy, or at least potentially de-escalating adjuvant therapy in early breast cancer, where we'll be focusing on the data from the TAYLORX study, looking at genomic testing of primary tumours to guide chemotherapy use, and secondly the PERSEPHONE study, which was a trial looking at duration of Herceptin. The other area I want to focus on is in advanced disease and further developments in the use of CDK4/6 inhibitors, looking particularly at the role of abemaciclib and ribociclib. And finally, just a few words about bone-targeted agents in the adjuvant setting and the findings from the DCARE trial. So firstly, the TAYLORX study. So TAYLORX is a trial, a phase 3 trial of chemoendocrine therapy in women who have undergone Oncotype DX testing of their primary tumour and have been found to fall into this intermediate risk category, which I'll define. So this study was presented by Dr. Joe Sperano on behalf of many colleagues and was a really large trial. So they recruited 10,270 patients, tested all these patients with the Oncotype DX genomic platform, which provided the three risk groups that we're familiar with. A low risk group, which were treated with endocrine therapy, as we would normally do in clinical practice. That was about 1,600 patients. A high-risk group, in this study defined as a score above 26, and these patients were treated with chemotherapy, as we would normally do, and there were about 1,400 patients in that category. And then the majority fell into this intermediate group, so that was 6,700 patients with intermediate risk breast cancer, for whom we really don't know whether we should be giving chemotherapy or not. And so what they did was they randomized the patients with this intermediate risk score to receive chemotherapy or not alongside their endocrine treatment. The chemotherapy used was predominantly docetaxel cyclophosphamide or an anthracycline-based regimen, 4 to 6 cycles. To get into this study, women had to obviously have breast cancer, but they had to be node negative and they had to be estrogen receptor positive and HER2 negative. This was all determined in local laboratories and not centrally assessed. And the tumor size could be anything from 1 to 5 centimeters. And of course, the patient had to be willing to receive chemotherapy if she was assigned that. The primary endpoint was invasive disease-free survival. And in terms of the characteristics of the patients, the median age was about 55. And of course, postmenopausal women predominantly were treated with aromatase inhibitors. In the premenopausal setting, a minority received ovarian suppression plus the usual tamoxifen. What we saw in this study, I think, is potentially practice changing, because in the important intermediate risk group that were randomized between chemotherapy and no chemotherapy, we saw absolutely no difference in outcome, indicating that the chemotherapy did not add to endocrine treatment in these 6,000 patients with intermediate risk scores. The hazard ratio was 1.08, the p-value was 0.26, and so clearly for this group of patients it's hard to see that chemotherapy can add anything other than toxicity for the patient. The same was so for distant relapse-free survival, relapse-free interval and overall survival, so really no advantage to giving chemotherapy. Of course, for the higher risk patients, these should still have chemotherapy, and there we saw a 13% relapse rate at 5 years, despite chemoendocrine therapy. So I think that's a nice clean result. Of course, Dr. Sperano went into some of the details of the study, looking particularly at the influence of age on outcome. And here the study becomes a little bit more complicated, because what he showed was that in this exploratory analysis in the under 50s, particularly at the higher end of the intermediate risk range. So this is patients in the 16 to 20, 21 to 25 range rather than 11 to 15. For the under 15s, there was a small benefit of chemotherapy. Now, whether this is chemotherapy per se or chemotherapy-induced menopause adding to endocrine therapy is impossible to say. But I think for clinical practice, and my take-home message on this was that if your woman is postmenopausal and she has intermediate risk on oncotype, you don't need to give chemotherapy. If she's young and intermediate risk and at the high end of that intermediate risk group, then you probably should talk to her about adding something to tamoxifen, either ovarian suppression therapy or chemotherapy. Overall, this is a very well done study, a very large study. I think this is the best data we're going to have on this area and something that I think is going to change our daily practice. The second study, which is also in this area of trying to de-escalate therapy for early breast cancer, is a trial known as PERSEPHONE. This was a trial comparing 6 to 12 months of adjuvant trastuzumab alongside the usual chemotherapy and endocrine treatment. We've had two previous studies in this area. The French FAR trial, which showed that 6 months of therapy was not non-inferior to 12 months treatment, and the smaller Greek HORG study, which also failed to show the benefits of the 6-month therapy. And Persephone started at about the same time as these trials, which is a larger study. It randomized 4,000 patients looking for a non-inferiority margin of 3% between 6 months and 12 months therapy. Now, the patients who went into this study were your typical early disease patients. They were well balanced between the two arms. Nearly 60% were node negative, and around half had tumours less than 2 centimetres. So these were at the better end of the prognostic spectrum, as you might expect in a study looking at giving less treatment to patients. About half the patients had their trastuzumab alongside chemotherapy, with the other half having it sequentially in the way that we used to do in the HERA trial. What Dr. Earle and her colleagues showed was that in terms of the primary endpoint, the disease-free survival at 4 years was 89.8% for the 12 months therapy and 89.4% for the 6 months therapy. So therefore the difference between those two groups is negligible, and the 95% confidence intervals did not cross the non-inferiority margin. So this study, unlike the previous two trials, suggests that 6 months therapy is probably as good as 12 months treatment. Now, of course, there are always more details when you drill into the study, and when you look at the subgroup analyses, you do see some differences in favor of 12 months therapy. For example, ER-negative patients seem to be doing a little bit better with 12 months therapy. Patients who received concurrent chemotherapy seem to benefit more from the longer duration treatment, whereas sequential it seemed to make no difference. And similarly, those patients who had taxanes seem to be doing better. Overall survival was the same, and of course, as you'd expect, if you give less treatment, you get less toxicity, and so cardiotoxicity was obviously less of an issue with the 6 months therapy. So this trial clearly is at odds with the FAR and HORG trials. My take-home message from this study was that if you have a relatively older patient with comorbidities and you're worried about the toxicity of trastuzumab, then I think one can feel fairly relaxed about cutting back to 6 months treatment. However, for me, I think the duration of trastuzumab is perhaps not the most important question, and I think we've learned about new things since this trial was initiated. For example, reducing the chemotherapy burden alongside trastuzumab and using something like weekly paclitaxel plus trastuzumab for better risk patients. So I think this is an important study. I think it gives confidence to those of us who are having to cut back on therapy because of comorbidities or cardiac toxicities, but probably for the majority of patients, 1 year of trastuzumab will remain the standard of care. Over the last 4 years, we've seen a revolution in the way that we treat ER-positive metastatic breast cancer with the advent of the CDK4/6 inhibitors. And at this year's ASCO 2018 meeting, we saw some more data which help place the role of these agents into our clinical management algorithms. As you know, we have 3 agents available, palbociclib and ribociclib, which are very similar, and then abemaciclib, which has some differences in its activity, mechanism of action, and adverse event profile. We've known for a few years now that the CDK4/6 inhibitors greatly improve duration of response to endocrine therapy in the first-line setting with letrozole or an aromatase inhibitor, and in the second-line setting with fulvestrant. At this year's ASCO meeting, we saw the first data from the MONALEESA-3 trial. And this differed a little bit from what we've seen previously in that it was a combination of ribociclib, the Novartis CDK4/6 inhibitor, in combination with fulvestrant in postmenopausal women, including first-line therapy patients. So previously, the fulvestrant combination has always been in the second-line setting, and here we saw data in first as well as subsequent lines. The study design was very straightforward. Like all the trials, it was a combination of endocrine therapy plus CDK4/6 inhibitor, given as ribociclib usually is on a 3 weeks on, 1 week off schedule, or placebo. And the primary endpoint was progression-free survival, assessed by RECIST criteria. Around 700 patients were recruited to this patient, randomized 2-to-1 in favor of the CDK4/6 inhibitor, and the hazard ratio for progression-free survival was 0.59, with a p-value which was clearly significant at considerably less than 1 in 1,000. So results that are very similar to what we saw with ribociclib plus letrozole and the other CDK inhibitors plus letrozole in the first-line setting, but showing that fulvestrant is an alternative partner and potentially could be considered in place of an aromatase inhibitor, particularly for those patients who perhaps only recently come off adjuvant AI therapy. And Dr. Slayman's conclusion in his presentation, and one I think that I could agree with, is that for him, this is the new standard of care for first-line therapy for ER-positive breast cancer, CDK4/6 inhibitor plus fulvestrant, and holding back other treatments for later lines of therapy. In recent years, we've realized that bone-targeted therapy is not only good for bone health, but can affect the outcome for women with early breast cancer, particularly in the postmenopausal setting. And adjuvant bisphosphonates are now part of international guidelines as part of our treatment approach. At this year's ASCO 2018, I had the privilege of presenting the results of the DCARE study, which was a large adjuvant trial looking at the role of denosumab, the antibody to rank ligand, to see if this could also improve disease outcomes in early breast cancer. This was a very large randomized trial of 4,500 patients with stage 2 and 3 breast cancer receiving standard adjuvant systemic therapy and appropriate local regional treatments. And they were randomized to denosumab, 120 milligrams given every 3 to 4 weeks alongside chemotherapy, and then maintenance every 3 months to 5 years, or matching placebo. And the primary endpoint was somewhat unusual. It's what was called bone metastasis-free survival. So that is the development of bone metastases either as a first event or later event, or deaths due to other causes. As I mentioned, patients had to have stage 2 or 3 disease to be eligible. They could have any ER or HER2 status, and they obviously couldn't be on any bone-targeted therapy to be eligible. The patient population was about 3/4 treated with adjuvant therapy, 1/4 with neoadjuvant treatment. About 20% were HER2 positive, 75% were ER positive, and almost all patients node positive. This chemotherapy was, as you would expect, most patients receiving anthracyclines and taxanes, and just over half the patients on endocrine treatment received an aromatase inhibitor, and 80% who were HER2 positive received trastuzumab. In terms of the results, this was a disappointing study because the primary endpoint showed no difference between the denosumab treated patients and the placebo patients, with a hazard ratio of 0.97. Similarly, for disease-free survival, no difference was seen. And the only positive endpoints were in terms of time to bone metastasis as a first event, but this was more than compensated by an increase in relapse outside bone. There were fewer fractures, as you might expect, fewer skeletal complications after recurrence, but clearly the conclusions from this study are that this agent is not working in the same way as a bisphosphonate. It's not improving disease outcomes in early disease. And so in my practice, and I suspect in the clinical guidelines, bisphosphonates will remain the recommended bone-targeted treatment in early disease. And denosumab will only be considered for women at very low risk where fracture is a much bigger concern than their breast cancer coming back. So overall, we're clearly in a good place with breast cancer, with increasing numbers of women surviving their disease and living decades after diagnosis. And so where we're going at the moment is to try and identify new treatment approaches in the advanced disease setting. So that's better endocrine treatments like the CDK4/6 inhibitors, maybe other agents that affect the PI3 kinase pathway, potentially immune oncology products, showing that they work in metastatic disease, and then trying to test them in the adjuvant setting, but in specifically targeted populations, either just at very high risk of recurrence or with specific biomarkers that might predict treatment benefit. The days of large, unselected randomized trials in the early disease are probably over. They often miss the treatment benefit that we're aiming for, and we have to wait 10 years for an answer. This is not lung cancer where you get an answer in 18 months. In breast cancer, we now have to wait 10 years to get an answer, so we have to make sure that we test the right thing in the right patient with the right trial design. And I think that's probably our biggest challenge for future development.